Well, thanks for having me. Sorry I couldn't be there in person. My son's a senior in high school. I had his first big football game last night, and I wanted to be there for that. So
What?
thanks for letting me be there virtually with you all. Great to be with friends, even remotely. I wanted to present something that had to do with open and MIS decision making for deformity surgery. It's an evolving world, a moving target, but this is sort of an updated perspective. I'll touch on actually some of the things that Roland was talking about as well, but just some practical application of how you think about deploying these approaches when you see deformity patients. So disclosures here, nothing really relevant to this particular topic. Everybody's fairly well aware of minimally invasive surgery benefits in general. In deformity, there are some specific areas that we've done research on and suggested that maybe there's exceptional benefits, such as blood loss. And you can see here an average of 430 cc's versus 2 liters. ICU requirements with Neil Anand's series was essentially nil, which was a striking difference from the typical open cohort. And then another big cost driver and potential benefit of MIS is the ability to get patients home, not only more quickly, but get them home directly versus going off to rehab. And so these are potential benefits to consider MIS deformity correction. Some of the other factors that made us consider MIS when we looked at this series of patients with a matched propensity, matched cohort of MIS patients, open patients, and then what we call hybrid, which is a bit of both. And what we found was that we could achieve similar radiographic outcomes, and the PROMs were basically improved for all of those groups. But again, the blood loss was substantially less than MIS. And notably, in a lot of these patients with matched deformities before surgery, we were achieving some of those corrections with less levels of fusion and lower major complications. So these are definitely some areas of consideration if you can perform MIS in the right patients. In the cohorts, there were lower intraop complication rates with MIS as well, and the overall complication rates were trending towards less with MIS when you added them together. Interestingly, when we took a look at the circumferential MIS group, which is basically PERC screws, interbodies that are MIS, the complication rate was only 30%, and length of stay was equivalent to open in a time frame where we were doing a lot of stage surgery. Now that shifted. There was a time when we would do a lot of lateral interbodies, keep people in the hospital for several days, and then do the posterior, which really probably artificially escalated the length of stay, beyond which many of us changed our practice towards, which was doing it all in one day, and the loss of the length of stay then diminished. Um, Very importantly, with this particular cohort comparison, there was less OR time with MIS. So that will come back to that because it's an important factor in some of the decision making that I currently utilize doing MIS versus open. And at the end of the day, whatever you choose, MIS or open, the primary goal is alignment, alignment, alignment. It should not be a goal to do MIS surgery. The goal should be getting your alignment first. And if you can achieve that with MIS, then there may be rationale to do that over open. So when does it make sense? That's also evolved over time. I would say that when you can limit levels, that's where it really shines. Degen Scoli L2 to 5 is a great place for it. You can get powerful correction and limit a fusion in that area versus having to do a much longer open posterior surgery to gain control over that curve. An L2 or L3 to pelvis for sagittal realignment really is quite powerful, and you can do it percutaneously on the backside in most of those cases. Lumbosacral corrections also work great. So cases like this where you have a scoliosis um, that's quite focal and more focal pain generation, you can get away with relatively very minor morbidity and still manage patients quite effectively with an MIS surgery, not necessarily trying to correct their deformity. You might correct a smidge, but really focused on their symptoms in the framework of their deformity. It's also something that can limit the extent of the surgery, and really can shine in older patients. This is a 88-year-old woman with a obviously fragility fractures, retropulsion into the cord, two-level disease and significant kyphosis. And ordinarily this would take a fairly extensive open surgery to gain control, to really get mechanical advantage in lousy bone. With an MIS technique, you can get better structural support, as you see here, augment the screws, and then get her going with a lot less morbidity than what would typically be required with an open surgery and less extent posteriorly. So another place where it shines. Another elderly gentleman with a degenerative lumbar a deformity that's quite mild and granted more radiculopathy and weakness, but this is another area where a big open surgery is tough to stomach for an 86-year-old gentleman, and you can get this accomplished with good sagittal maintenance or realignment at the lumbosacral junction and percutaneous fixation, and get him home with a modicum of risk in relative terms. MIS deformity surgery is not new. Some of the folks nearby you, Raj and JC and others, have looked at this with ACRs, anterior column releases, and comparing that technique for sagittal realignment with pedicle subtraction osteotomies, and really found a striking difference in estimated blood loss, and notably, and granted probably with some older PSO techniques, a differential pseudoarthrosis rate. And not to be undone, Mike Wang has looked at MIS ways of accomplishing even PSOs. So that sort of technique now allows one to consider getting a sagittal correction of more acuity in the lower lumbar spine through a minimally invasive approach. Mike's done a fair number of these. We've done them at Scripps. And so it's no longer true that even a PSO must be handled in an open fashion. This is obviously a fairly technically complex maneuver to do MIS, but the point is there's an evolution in MIS techniques that allow us to tackle more and more over time in deformity, tumor surgery. And so there are things to be considered in altering the equation of when one does one versus the other, open versus MIS. So now MIS isn't for every case, and you have to be particularly aware of things like bony dysmorphic fractional curves. You can see here a patient that's got this asymmetric trapezoidal L5 vertebra. If you put interbody spacers between L5, S1, and L4, 5, you are not, in their symmetric, in their stock format, you are not going to change that fractional curve. And an MIS approach to this without considering that will likely bake in or even worsen a coronal deformity. And what Roland talked about with customized implants can potentially mitigate that, but it's something you have to be acutely aware of in your planning when you're considering deformity correction with an MIS approach. This is a 73-year-old physician who had low back pain and radic and minor degen scoli. Looks like a potential candidate for MIS surgery. Got lateral interbodies, and this was done in the days where we staged things. Resolved his leg pain, and you can see this residual fractional curve. And sure enough, we got him up in between stages, and you can see coronally, we really powerfully corrected his degen scoli in the main curve, but he's got the fractional curve remaining and a worsened coronal global alignment. And so we took him back with that in mind and addressed that at the base. But if you go in without considering that, or you do a single stage, or you're sort of thoughtlessly throwing in perk screws after that, you're going to find some discontent in the coronal plane. So in the preoperative planning stage, you really want to look at the sagittal and coronal alignment, both anticipate, in particular, the coronal plane change that you're going to accomplish. Lateral interbodies as a rule, are extremely powerful at correcting coronal deformity. But if you have a main curve that is compensatory to a fractional curve, you can create some real problems. And it's exceptionally difficult to correct from the back without an asymmetric PSO. So sacral promontory asymmetry goes into that same category. You will get patients that have trapezoidal L5s, but you also have sacral bony dysmorphic nature that is the driver for the lumbar curve. And so you want to look at coronal films. I find that coronal x-rays are particularly unhelpful, but coronal recons of CT scans, and if you can get them to do MRIs, those can be helpful too. Really understand the sacral promontory and its coronal relationship, and then design your plan in MIS surgery around that. And like I said, that may come down to asking for coronal taper custom implants. That is the new age for managing that problem. Perhaps in some of these patients, the blue collar sort of cost efficient way can also be rotate a standard implant. So if you're trying to achieve a 15-degree change at L5S1, but you need 3, 4, 5 degrees of coronal change in that alignment at that segment, the other option is to basically rotate that 20-degree cage in the direction that you need to lift, so that you convert some of that sagittal profile of the implant to coronal profile. And then it's just trigonometry. You're trading some lordosis of the segment to coronal change, and then go to the back, and you might have to do some releases to get it to shift. Over time, as I said, we've gotten fancier, and technology's helped us improve our capabilities of MIS corrections. And so that's led to some of these iterative algorithms. This is the MISDEF2 that the MIS ISSG subgroup came up with to really guide us all in when it's appropriate to attempt an MIS reconstruction. You can see here, I won't go through or belabor the algorithm, and this is published, so you can pull it down from PubMed or wherever you get your literature. But essentially, these 4 classes give you a guide on when to use open versus MIS. And you can see your class 4 in general, which is going to involve a multi-level fusion, more than 5 levels, greater than 10 segments, including 5-1, to require an open type surgery with osteotomies in general. As I mentioned, there is the potential mini open PSO that could factor into that, but in general, you're going to go open with that more extravagant deformity. Beware of limb length inequality. Factor that into the plan. That's true for both open and MIS. But when you do MIS surgery and you put these interbodies in the disc space, and you then put the patient prone, you will lose some of the capability to manipulate the spine. It's just simply harder to compress asymmetrically through disc spaces, or get a little tweak in coronal alignment. So if there's an uncertainty, I will lean towards open posterior, and leave interbody spaces open so that I can adjust in cantilever fashion through those disc spaces to adjust coronally. In general now, as these techniques have evolved and I consider all of these factors, I'm a bit more often going to go open posterior when I'm at the T10 level, or certainly above that. Um, if they're if they're in the L2, L1 region and with healthy anatomy above that, then MIS can serve a great um, purpose in limiting the number of levels and perhaps some better function for the patient. But in general, the minute I'm going to lower thoracic spine T10, I'm now a bit more considerate of going open for a few reasons. One is it's faster, so less anesthesia for the patient and probably economically more favorable overall for a variety of reasons that come down to implant cost, our ability to move these patients in and out of the hospital more effectively with the anesthesia and pain control techniques. And even our own data really suggests that if you control in this propensity match group for the number of levels fused, the MIS group just takes longer. There's an additional hour of surgical work done to accomplish the same goals. And I think we have to be thoughtful about that from a cost utility perspective and health economic perspective. Just a few examples of where MIS can get you off kilter and where you have to be more thoughtful. We used to put these very lordotic cages in not only at the base of the spine, but in the mid and upper lumbar spine. And depending on Rousselet shape, you can see here patients really can get hyperlordosed. So one of these learning points from the early areas of ACR and laterals in general is it was that we weren't adherent to Rousselet shape. We were hyperlordosing the upper lumbar spine and creating PJK risk. And then this is an example of that fractional curve plus hyperlordosis. You see here the fractional curve at the base, and then the post-op here you can see we're off coronally and hyperlordosed and created basically a negative sagittal plane deformity and a PJK risk, which you can see they went on to. Again, post-op fracture. So really, I think our group is generally a bit more focused on the Rousselet type and really trying to shape the spine, whether it's MIS or open, be very careful about mid and upper lumbar spine hyperlordosis, much more likely to use a neutral or a 5-degree cage in the mid and upper lumbar spine. So I've got some luxury to adjust from the back. If you put a 15-degree cage at L2-3, your ability to correct that out on the backside is much more limited. So generally, if the patient's needing reconstruction above L3, I'm a bit more considerate of an open versus MIS to make sure I'm managing that upper lumbar spine appropriately. And as I said, avoid that hyperlordosis. So where the home runs with MIS, definitely if there's a way to minimize the fusion levels and do selectives, degen scoliosis with preservation of L5S1, I think it really shines. Thoracic focal focal kyphosis, flexible deformities, open disc spaces, obviously, and there's now the capability to do single position, lateral ALIF, and laterals above that, which accelerates the surgical time. And where should you be careful? Well, we talked about the fractional curves, whether it's disc or bony dysmorphism and sacral asymmetry, rigid or ankylosed spine, prior fusions, going to be more challenging to correct in that way. And where you need really extravagant sagittal corrections, particularly with fixed deformity and additional thoracic deformities. The other thing we've learned is that lordosis distribution matters greatly. This is work that Debo and Alan Daniels spearheaded for our group at ISSG. And without getting through all the results, the conclusions are what matter. And the technique really didn't matter in restoring alignment. They were both capable of doing that, but restoring that lordosis in the appropriate location in the lumbar spine, cephalad versus caudad, and making those areas normative is really the key to success. And so whether you apply open versus MIS, it's more about your ability to focally manage things properly, normatively, and then use open surgery for longer corrections. thoracolumbar curves that extend into the thoracic spine substantially, and managing compensatory curves when they are stiff and unmanageable otherwise, and really be sensitive to the normative shape of the spine. And I will say, just reflecting on Roland's talk, um, the whole age adjusted paradigm is a matter of escalated debate, I would say, in our group. I think Jeff Hill and Mike Kelly, Greg, and I have leaned a bit more towards focusing on normative rather than age adjusted, um, understanding that the more recent data is really more compelling to look at lumbar pelvic angle, T4 pelvic angle, and try to get those matched up with a normative ratio versus age adjusted. So just food for thought and open for questions. Thanks for having me.
Well, thank you for the great talk. Obviously, very tricky subject. All of us want to do best for our patients. One of the things that I have struggled with a little bit in trying to push the envelope in doing more MIS deformity cases is passing the rod. Sometimes I feel like I'm really traumatizing those paraspinal muscles. What are some of the techniques you can offer us for, just reducing that morbidity? Because at a certain point, it's probably easier just to do it open if you're really going to be just mauling that paraspinal.
Right.
So
Yeah, very good point. There's a whole art form to how you manage the soft tissue, I think, and I'm not a big fan of the train tracks, the little pokes all the way down to put screws in. I think that, you know, for one, it just cosmetically looks less appealing. So I've actually moved towards in MIS cases that are basically above L2, I'll make a midline skin incision. And then because the skin's really irrelevant to MIS, it's all the soft tissues below that that matter. And then I'll get wires through the fascia first, and then between wires, I'll make an incision by twos. And that allows me to get towers through that, but gives you a little play for the rod to pass all the way down and you can see a little bit better. The base of the spine has also been an issue with MIS and putting iliac bolts or S2AIs in, and that was a little bit of a learning curve. The midline skin incision allows you to make a midline fascial incision at the very base over about S1 so that you can get wires into the sacrum and ilium. I typically use S2AI screws, but you can use standard sort of low riding iliac screws in that case. But the soft tissue management for me is fascial, midline skin, fascial split, but I don't split fascia all the way down. I do it by two wires at a time, essentially, so that I can get the towers in, and it's just a little more conducive to passing the rod all the way down without feeling like you're beating things up on the way you kind of guide it from skip fascial approach to skip fascial approach.
And in one of those, I saw kind of sometimes you do need a hyperlordotic curvature. Do you find that coming from the top to the bottom, that can obviously be challenging? What do you think has worked best in your hands?
So the hyperlordotic, you're right, can be a little bit more challenging, but I almost always still go from the top. And what that means, when you open the skin like that and you're not trying to work through the skin at the top and you're just working with the fascia, you allow yourself to have a steeper angle coming through the top tower, which favors that lordotic bend at the base that you're trying to slide through. The other area where it can be a bit more challenging is going from the S1 screw to the pelvic bolt, because you've got some more dense fascia there. And if you find that that's a little bit of an issue, you have to you can open the fascia up slightly between those 2 points, between S1 and S2AI or S1 iliac bolt, just to prevent yourself from riding up and over that fascia. That's a one area of beware point, because I have seen the rod pass over the fascia between S1 and iliac bolt, and then when you're trying to reduce the rod, if you're not aware of that, you're applying this huge load against the fascia, and you can actually yank S1 screws out. Iliac bolts usually do okay.
Great, thank you. Any other questions?
Rob, thanks. That was great, great overview. Can you just maybe help define us a little bit? I know you put the three goals as alignment, alignment, alignment. I usually add fusion as one of those goals as well.
Yeah.
And maybe you can discuss how fusion is achieved through the posterior. And then perhaps maybe just why don't you define for everybody what a hybrid and MIS, in your opinion, would be as opposed to an open in terms of approach and things that what it entails.
Sure. Well, of course, we want to get fusion. The good news with MIS is most of the time that means we're using anterior column support and we're getting there through an MIS approach. And that historically has been very powerful at fusion, very successful, as you saw with the work even from Raj and JC next door. So the fusion rates are quite high. Where there's been some debate is how do you get a fusion MIS if you're not doing interbody? And there's different techniques for doing that. You can, even Roland will use a sort of parasagittal approach down to the spine, burr out the posterolateral spine and the facets, and then apply graft in that way and preserve some of the midline muscular structures. Otherwise, and I know Neil does the same when he's working above any interbodies. So you can still get an MIS fusion sort of technique without an interbody. The success of that fusion rate, I think, has not been well evidence-based yet, but that's the approach. So that brings up the next question. What is circumferential MIS? What is hybrid? Hybrid classically, or at least the way we define it, was when we would use MIS interbody approaches, like a lateral interbody, an MIS TLIF approach, and then applied an open technique on the back. Basically, just open it up. You didn't have to get as wide and be as aggressive with the fusion, but you still had to open up to do PCOs or do some sort of work on the back. So it's MIS front, open in the back. That's a hybrid. The circumferential MIS is perk screws, essentially preserving that posterior soft tissue envelope with the MIS interbody technique.
Great, thanks a lot.